So we are back on Dr. Pepper and we are doing some more questions on this website. I hope you guys are there. Hope you guys have been enjoying it. There's been a new signups and I'm currently making a game as well for Dr. Prepper, which should hopefully be a little bit more fun and allow you to go through all of the content for the UKMLA curriculum. But what are we doing today? I am currently revising for the FRCO Part 1 for ophthalmology. I think that's a specialty that I want to apply for. So let's go and do some questions here, because my questions, my understanding has definitely not been the best. But you know what? Let's do it. Let's make sure everything is recorded. Okay. So what do we have here? A 61-year-old woman presents with sudden flashes of light and the appearance of floaters in her right eye that started 3 days ago. She describes seeing cobweb-like shadows. She denies pain or redness. There's no history of trauma, recent eye procedures. Examination shows reduced visual acuity but no external abnormality. She is worried the vision may get worse. And here's a summary of the exam. Corrected shadows, no pain, redness or discharge, no trauma behind myopia, no systemic neurological symptoms. Worried about rapid vision deterioration. Visual acuity reduced in effective eye. Fundoscopy revealed detached retina, corrugated appearance, no conjunctival injection, normal intraocular pressure. So this would rule out things, I guess, from your differentials like glaucoma because of the pressure, and no conjunctival injection, ruling out things like, let's say, maybe episcleritis, scleritis. Okay, so what are we thinking then for the differentials? I think the first one I'll probably say retinal detachment. That seems to be a reasonable guess. No redness or pain. Seemed to have just happened. She was worried about the vision may get worse. The correct hurting coming down. Maybe another one, optic neuritis or something like that. Even though it's much lower on my list. Visual acuity is reduced in the affected eye. If I'm going to reveal detached retina, corrugated appearance. Oh, my light just died. Let us plug in this light so we can get some better vision. Okay. So let's do those ones for now. Retinal detachment, okay. Posterior vitreous detachment, flashes floaters but no shadow, and central retinal artery occlusion, visual loss but no flashes floaters. Okay, that makes sense. So two, really just one of them. So probably get a score of 1 for that one. Investigations for retinal detachments. I believe you probably need to do an OCT. Just to make sure there's nothing else going on. I probably want to do like a cranial nerve exam. Fundoscopy. Not worried about infection or anything like that. No trauma, pain or redness. Discrepancy coming down. I have not done this question in a while. What the rescue fundoscopy may reveal? Yeah, I think that's pretty much it I can think of right now. Fundoscopy, OCT, cranial nerve exam. Okay, ocular ultrasound, OCT, macular development, expected visual acuity testing, which would come under the cranial nerve exam. Ocular ultrasound and fundoscopy is inconclusive. Ocular ultrasound, I'm saying 3, because I think I did quite good there. The measurements from retinal detachment, I think immediately I would refer to my senior, especially if you're like an F1 seeing this patient, if you're working in ophthalmology or A&E. Refer to senior. The person needs to be, I believe, like urgent, same day referral to ophthalmology. There's different managements. If I can think of from memory, there's like a bubble management where like they inject something like your vitreous that pushes the retina back. What else could I give them? Maybe manage them conservatively in the meantime. Counsel the patient of what's going on because she's quite worried. Make sure that we're being very holistic in how we treat her. What is this thinking? Surgical repair, yeah, but surgery. And yeah, that's what's called pneumatic retinopexy. So, actually, no, I was thinking of slow walking. Post-operative position advice, okay, so that's counseling. Avoid heavy lifting activities that raise intraocular pressure, and long-term follow-up for fellow eye. That's could probably give a 1 there, could have done a little bit better. Let's look at high yield. So retinal detachment presents with flashes, floaters, and shadow or curtain-like vision loss. It is an ophthalmic emergency because delay in treatment risks permanent vision loss. Teaching includes the role of urgent referral, types of detachments, and the surgical options. The UKMLA may test on differentiating retinal detachments from posterior vitreous detachments and retinal artery occlusion, one of which presents with acute visual changes but different findings and urgency. I hope that makes sense for you guys. So you can save the answers there. Then on Dr. Pepper, you could always just go back to your progress and then see how you're doing on these cases again. So the averages obviously aren't really good, as we can see. We can see the scores that we've been getting for the differentials, what we get for the investigations, for the management, and just really see where you need to work on. Then you can go over here and see like the actual cases that you have worked on. So if I select a specialty there, let me see, make sure that's saved. For example, here's the cardio case that I did before. The average score for the specialty was 59%, even though like this is the average just based off of one case. Obviously, yeah, as you do more cases, you'd get more accurate average. But this case score itself was 44%, so definitely needs some improvement over there. Let's go back and do some more ophthalmology cases. It is the ophthalmology day. Or should we do derms? I clicked on that by accident. 30, so sudden appearance of a painful skin lesion. A 30-year-old man presents with rapidly appearing painful red lump on his lower leg that developed over the past 3 days. It started as a small red spot and has now become a raised, tender nodule with surrounding redness. He denies any fever, trauma, or previous similar lesions. He has no significant past medical history. Examination reveals a 3 centimeters tender red nodule with a central area of fluctuance. There's no lymphadenopathy. He's concerned that the vision is that the lesion is worsening and he may need intervention. So we have a rapidly enlarging painful red lump over the leg, no systemic symptoms, no trauma, insect bites or previous abscesses, no significant medical history, no recent travels, tender red fluctuating nodule central points, no cellulitis spreading on lymphadenopathy. Well, so what is going on? Okay, this is interesting. So we have a tender erythematous nodule with a central area of fluctuance. There's no lymphadenopathy, and he's concerned that the lesion is worsening and he may need intervention. But it doesn't seem like there's any systemic symptoms. So I guess just with any sort of skin infection, you probably have to have cellulitis here, even though it doesn't typically look like this. I'll probably say maybe like an infected cyst of some form. It says no cellulitis or spreading lymphadenopathy, so we'll probably have to have this much lower on the list. What else could we say? So we have like a tender fluid-filled cyst that is worsening. Maybe like an infected cyst, infected mass or cellulitis. I think that'll be fine for now. Foreign cold or boil, which is a localized infection of a hair follicle. I'm gonna give myself the mark for that. Epidermoid cyst, inflamed, left cubic become secondarily affected. Pyoderma gangrenosum is rare, also rates quite quickly. Let's give ourselves a number 1 for that one. Investigations, even though there's no like systemic symptoms, but we want to get like a skin swab, maybe do some general blood tests. FBCs, look for white cells. CRP, look for signs of inflammation. I'm not worried about systemic symptoms, so I probably wouldn't do a VBG at this point in time. Anything else I would do? So if we're thinking it's like a boil, I don't really think there's much that we can do. Swab, if recurrent, MS, array screening and recurrence of severe cases, and imaging of deep abscesses is suspected. So a lot of these are just like in case. So I'll probably say a 3 for this one because it's mainly just a skin swab that you really just do for this one. Management plan, again, counsel the patient on what is going on the boil. So safety net to return if worsening of the boil. Systemic symptoms such as fever, raised heart rates, chills. Let me see. We'll follow him up with swab results. Probably as a GP. Probably will need to come back in, or maybe just contact him if there's any problem. I don't know if we need to give him antibiotics. So it seems like if it doesn't resolve, if it doesn't resolve, so you may consider antibiotics in the future. But as of right now, probably just chill with that. Just conservative management, like keep area clean. Keep area clean, maybe don't pop it, allow it to drain. Don't pop it. Just allow it to self-resolve. Well, I'm going to consider drainage. Incisional drainage is a good one. Empirical antibiotics cellulitis with systemic signs, educate on hygiene and avoid skin trauma, which I said, and then treat underlying risk factors. Okay, so this is a really good one, because it could be, he has diabetes or immunosuppression that's causing this wall, so a good thing to treat that's maybe refer to GP if you think you're suspecting things like diabetes. Incisional drainage as well, say 2 for that one. So a furuncle or boil is a painful infection of a hair follicle caused by staph aureus or those common areas of friction, sweat, and poor hygiene. Early small lesions may resolve with warm compresses, but larger fluctuant abscesses require incisional drainage. Antibiotics are reserved for cases with surrounding cellulitis or systemic involvement. Teaching should include infection control measures, unnecessary considerations, and the importance of investigating for underlying diabetes or immunosuppression in recurrent cases. UKMLA may test on when to escalate antibiotics on sepsis. Red flags. So let's save our answers there. We're doing pretty good. Let's leave the site. Let's go back to ophthalmology, because after this, we're just going to do Anki cards. After maybe make some more short videos for my fitness channel. Oh, is this? Okay, I need to give myself a pro subscription. I need to upgrade. That's probably why it's asking me to pay. Is anyone here at the top free? Okay, lovely. We have one. We have some free on my own website. So you can always, I think there's like 50 cases free on my Dr. Prepper website. But of course, if you upgrade and get any of the subscriptions, then you get everything free, all 500 cases, over 500 cases that cover every topic on UKMLA. And I'm also creating a game as well. And the game, it should be a little bit more fun and lighthearted. And again, that game will also cover every subject in UKMLA. But if you have a subscription already on Dr. Prepper, then you get the game for free. Otherwise, it'll be a one-time payment of like £12. Then you can use it forever. But if not, yeah, then go on Dr. Prepper. So sudden blurred vision in one eye. So 68-year-old man presents with painless loss of vision in his left eye. That started 1 hour ago. He described it as a curtain descending over his vision and denies any pain, redness, or discharge. He has no history of trauma. He has long-standing hypertension and type 2 diabetes. Examination reveals no light perception in the left eye, but no external abnormalities. He is extremely anxious about whether this vision loss is reversible and fears a stroke. So yes, sudden painless complete vision loss in one eye, curtain over, no presenting trauma, history of hypertension. The visual acuity shows no light perception in an affected eye. Normal people shape but relevant. Afferent pupillary defect presence. Photoscopy shows a pale retina with a cherry red spot. For those of you that see this sign on PassMed, you know this is a characteristic diagnosis, no external eye abnormalities. So let's go and see what we have. One central retinal artery occlusion, my first one. Maybe there's another one, central retinal vein occlusion. Another sudden onset blindness, stroke. Okay. Retinal detachment, of course. Usually perceived by photo flashes, ischemic optic neuropathy, similar factors. This is actually a better one. Ischemic optic neuropathy. Well, central retinal vein occlusion. So just one for that one. I should have had at least this one here. Investigations probably say the same thing, like OCT. Probably full. I mean, he's done a visual acuity test, so probably that's like what, cranial nerves too. Maybe full cranial nerves. Consider CT head if we're thinking stroke. For endoscopy. Oh, that's already been done. Normal people. Maybe consider MRI. What else do we have here? OCT. The retinal layers. Carotid Doppler ultrasound for embolic source. Yes, this is a better one. Carotid Doppler ultrasound and ECG to assess for AFib, because AFib could have sent a clot up. That went up like the internal carotid artery, that went through the ophthalmic artery, then central retinal artery. Inflammatory markers exclude dry cell arthritis. So let's say one for that one. Oof, not doing too good here. Not doing too good. And the management for this one, I remember it vaguely. It's like you need to do something you need to dislodge the clot. I would say patient education / counseling of what's going on in the management. Same day referrals, same day. Urgent referrals to ophthalmology. You do probably management, so rate / rhythm control if you're thinking it's atrial fibrillation, so just depending on the time course. For AFib, so consider, probably if it's outside of the window, you probably want to consider anticoagulation in line with the Chadra score. Maybe even consider blood thinner, like right now. Yes, ocular massage is the actual management, so dislodge the emboli. So I said dislodge the clots, but I just forgot how they did it. Reduce intraocular pressure with acetazolamide or anterior chamber paracentesis. Initiates antiplatelet therapy. Okay, so you start aspirin. Urgent referral to stroke team for systemic vascular assessment. Long-term cardiovascular risk management. Okay, so not too bad. I'd probably say 2 for that one then. High yield information. Central retinal artery occlusion is a sight-threatening emergency equivalent to an ocular stroke. Patients present with sudden painless mononocular vision loss, and fundoscopy may reveal the classical cherry red spots. Prompt management aims to dislodge the embolus and restore retinal perfusion, but visual prognosis is poor unless treated within a short window. So teaching includes recognizing risk factors such as atrial fibrillation, hypertension, and carotid atherosclerosis. The UKMLA focuses on the importance of immediate action, multidisciplinary care involving stroke teams, and prevention of future vascular events. Let's save that. Can we get another case here? Is that free? Lovely. There's another free one here, guys. Probably a last one for today. So we have a red, painful eye with halos around lights. So a 55-year-old woman presents with sudden onset of red, painful left eye associated with headache and seeing colored halos around lights. She reports nausea and vomiting and blurred vision. The pain started about 6 hours ago and has progressively worsened. Examination reveals conjunctival injection, a mid-dilated non-reactive pupil, and corneal haze. She is visibly uncomfortable or worried about permanent vision loss. So we have acute painful red eye with blurred vision, sees colored halos around lights, associated headache, nausea, and vomiting. No trauma versus eye surgery. No prior similar episodes. No history of migraine. Conjunctival injection, mid-dilated non-reactive pupil, corneal haze, raised intraocular pressure. So obviously the first one, acute angle closure glaucoma. Second one, primary open angle glaucoma. What is that one called? Uveitis, anterior uveitis. Episcleritis. / scleritis. Cluster headache. I gotta think laterally as well. So acute angle closure glaucoma, anterior uveitis, scleritis. Classic symptoms post-examination, painful red eye, but usually constricted pupil, and anterior uveitis and painful, but vision is less affected. So I think we got all of them there. Investigations. Gonioscopy, I think it's called. FBC, CRP for white cells on CRP. ESR, look for signs of inflammation. Yeah, we definitely want to look at the angle as well of the eye. See what is going on there. Don't know if we need to do an OCR. Fundoscopy, has that been done? Fundoscopy. Sundial swabs, anything there? Slit lamp examination, tonometry to measure blood pressure. Oh, it's called tonometry. Gonioscopy to confirm angle closure. Done by ophthalmologist. Visual field assessment. Visual field assessment, of course. How did I forget that one? Blood pressure and systemic evaluation. So let's say like 1 was really the best. Acute angle closure glaucoma. Person has to, I believe you have to lie them down. Then start them on things like acetozolamide, timolol, so a carbon anhydrase inhibitor, beta blocker. Definitive management is isn't it like peripheral iridotomy? Or is that for primary angle? And you do this bilaterally as there's a risk of acute angle closure glaucoma occurring in the opposite eye. Let me see, patient education. Same day ophthalmology referral. Then maybe antiemetics, IV fluids. Analgesia. Let me see what I have here. So let me see about orally IV. Pain and nausea control, defense management, laser, peripheral iridotomy, lungs management, monitor for glaucoma, both eyes. Let's go. We got all 3. Let's go. High yield information. Acute angle closure glaucoma is a sight-threatening emergency presented with painful red eye, blurred vision, halos around lights, and systemic symptoms like nausea, raised intraocular pressure, Must be lowered urgently to prevent optic nerve damage. Teaching includes the classic signs of mid-dilated pupil, fixed pupil, corneal edema, the use of both medical therapy and definitive laser iridotomy. UKMLA may test recognition, safe initial management, and knowledge of glaucoma screening for the fellow eye, which is also at risk. Okay. Hope that makes sense, guys. I hope this video has been useful for you guys. Again, go on Dr. Prepper. This is my baby. I know it's the summer, but you can definitely just get started with doing some light cases here, over 500, like 50 free, so just do it. Sign up as well to the website, because I'll be emailing all of you guys there on how to best utilize it and to get the most out of this website. So yeah, just let me know what you'd like to see. You want to see more of these videos, let me know as well. And also let me know if you need any sorts of specific videos in regards to medical school, tips and tricks, OSCEs, examinations, Anki, all that good stuff. Let me know down below. And I'll see you guys later.